to Voices of Wisdom, TIRO's podcast designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. Think of it as a fireside chat where we talk to international experts who share their wisdom, offering practical advice to clinicians in a variety of common and sometimes complex clinical scenarios. I'm your host, Dr. Dana Hartle. I'm an otolaryngologist and head and neck surgeon at the Gustave Roussy Cancer Center in France. And it is a pleasure for me to welcome you to TIRO's Voices of Wisdom podcast. I will be hosting this second season of Voices of Wisdom, stepping into the shoes of Dr. Janice Pasica, who pioneered these podcasts. I want to take this opportunity to thank Janice for all her hard work on making these podcasts a reality, and congratulate Janice and all of those who contributed to the success that they have become. We created this podcast to provide clinicians with short, easy-to-digest highlights of clinical issues that we all face while treating thyroid cancer patients. Our aim is to share evidence-based information as well as practice-based experience and tips from world-renowned experts. In each episode, I am joined by distinguished international guests who bring their unique perspective and expertise to the discussion. So whether you're a surgeon, an endocrinologist, a pathologist, a medical oncologist, or a nuclear medicine specialist, this podcast promises to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients. We are excited to welcome Dr. Zubair Baloch to the podcast. Dr. Baloch is a world-renowned expert in thyroid and head and neck pathology, and a professor of pathology and laboratory medicine at the University of Pennsylvania. He has helped shape the modern standards of cytopathologic diagnosis, including his leadership in developing the Bethesda thyroid FNA classification and co-editing the Milan system for reporting salivary gland cytopathology. Dr. Baloch is co-author of the 2025 American Thyroid Association Clinical Practice Guidelines for the Management of Thyroid Cancer. With more than 200 peer-reviewed publications, global lectures, and decades of pioneering work, Dr. Baloch continues to influence how clinicians understand and manage thyroid disease today. In today's episode, we're joined by Dr. Zubair Baloch for an in-depth conversation about the evolving field of thyroid cytopathology. While cytology remains essential for diagnosing malignancies and selecting patients for surgery, interpretation isn't always straightforward. Dr. Baloch discusses the diagnostic challenges of indeterminate and follicular lesions and the expanding role of molecular testing. He also touches on the potential of artificial intelligence to transform cytologic assessment, or at least to aid. He also shares insights on global access barriers, future directions in the field, and practice guidelines for clinicians navigating Bethesda 3 and 4 categories. So let's get started. Thank you, Zubair, for joining us today. So we're going to dive right in you were the one that suggested the title Beyond Bethesda for the cytopathological diagnosis of thyroid tumors. We all know that cytology is major for diagnosing malignant disease and for selecting patients for surgery, but it's really not that simple. And I was wondering, what's your take on that? Are there any particular difficulties? Are there types of lesions that are really difficult for you? And what's your experience about that?
So if we go back to the basics, just a quick shot, cytopathologists can easily diagnose the most common carcinoma of the thyroid, which is papillary thyroid carcinoma, because the diagnosis is based upon nuclear cytology. And they can see the nuclei even with few cells on the slide, and they can say this looks like papillary thyroid carcinoma, or at least suspicious for papillary carcinoma. But when you look at the whole scheme of thyroid nodules, up to 95% are benign. And these include benign thyroid nodules, benign neoplasms, and even among benign thyroid nodules, these are proliferations. So when you have a cell proliferations, you're going to get lots and lots of cells. And because of this, when you look at a whole spectrum of thyroid lesions, you are going to get specimens which have all the features that come with a benign nodule, and you're very comfortable in diagnosing that. But then you have this middle group of lesions where you have many, many cells, and these are forming thyroid follicles, They have a lot of cells on the slide, they're overlapping and crowding, and even if they are coming from benign nodule. So going to the basics, FNA is a representative sample of a larger nodule. And depending upon who is biopsying those nodules, you're going to get a lot of cells. And as we know, there are thyroid cancers which form follicles. They do not have nuclear features of papillary carcinoma, and their diagnosis is based upon invasion, and that you can only see in resection specimens. You're not going to be able to see that in cytology specimens, and that's why those are the cases which are very difficult. And you will be, the cytopathologists will be calling them as indeterminate for malignancy or saying that this is a neoplastic growth, but I cannot tell you this is benign versus malignant. And that's where the difficulty comes in. So if you look at the top malignancy that we can diagnose as papillary carcinoma, when you have horrible looking tumors like anaplastic carcinomas or really high grade carcinomas, which have necrosis, funny looking nuclei on the slides, that's not a problem. But these do not form the majority of the cases that you see in everyday cytopathology. So this is where the difficulty lies on how to really diagnose those malignant lesions that they do not have great nuclear features, and the diagnosis is just based upon cellularity of the specimens and architecture.
And so if I understood correctly, then the diagnosis of a benign lesion, you're going to look at several different factors. Like papillary, you're going to the nuclei in particular, then maybe necrosis, but then for like something benign, you have a checklist of things that you look for and that has to fulfill all of those criteria.
So I think, so I've been practicing this for a long time. And so the reflection is that when you look back, I always tell myself and I tell my trainees that, the tumors and the lesions in an organ do not read books. They do not look at the atlas. They all can be different. So if you have a checklist, which is kind of applies in most of the cases that benign nodules have a lot of colloid. So the slides will have a lot of colloid, and especially watery colloid, which is filling up big spaces in a thyroid nodule, which appears on ultrasound as a spongiform nodule. So the radiologist who is pretty proficient in doing the biopsies will say, this looks like a spongiform banana-appearing nodule. And those are the ones that give you a lot of colloid. They give you sheets of cells, which are heterogeneous population, and macrophages. And that's when applies in a good majority of the cases. But as I mentioned, some of these nodules are proliferations, and we now know that even benign nodules, up to 70% of them, by molecular analysis, are clonal proliferations. So they're actually neoplasms at the molecular level. So when you biopsy these, and when you're biopsying one area, you're going to get that representative cells. You're not going to get the whole nodule. So that's why the difficulties arise. But that checklist of watery colloid, heterogeneous population of the cells, macrophages, fulfills the criteria for most benign nodules, but the lesions not always follow the rules.
Well, that's sort of scary to think that even something benign now is going to be heterogeneous and is already starting to want to become a cancer. That's from a molecular level. So what you're saying is when it's really, really bad, it's pretty easy. And when it's really, really good, it's pretty easy. And then the difficulty is everything in between. That's tough. That's very tough. And that gets to my next question. That's one of the problems is we're sending a lot of these patients to surgery, these indeterminate Bethesda 3, Bethesda 4 lesions. Do you see a future where, and I'm sort of a loaded question, where we won't be doing quite as much surgery on these, and how can we really, really safely avoid that?
So I think if you really look into what is available now, what is the current status of the thyroid FNA is, I personally think everything matters. A diagnosis is not based upon vacuum. So radiology is doing their thing, the endocrinologist is doing their thing, and the cytopathologist is just looking at the slide and just classifying it as Bethesda 1, 2, 3, 4, 5, 6. So for me, that does not serve our ultimate client, which is the patient, right? It's not about you, it's not about me, it's about the patient. So I think everybody has to take as much information available on hand to issue a diagnosis. And the cytology diagnosis is kind of a step which leads to how to manage these nodules. Naturally, the Bethesda 3s and 4s do make a big chunk of the diagnoses. But one has to also understand that if the radiology is very benign looking or very low risk looking, the clinical presentation is very clinically low risk. There's no family history. And what you are seeing, something that looks focal atypia. Let's say there's something focal in a specimen and you say this is atypical. So if you really look at the follow-up of those cases that are called on few groups of cells, atypical or indeterminate or neoplasm, the majority of them on cytology without involvement of any specialist studies are going to be benign. And when you look at the malignancies, the majority of them are going to be low-risk malignancies that can be treated by just lobectomy and really not a Gestalt total thyroidectomy approach. So I think if you take that background information and when you're looking at a case, it is advisable to really relay the information that what you think is atypical is very focal. All the information taken into account. Naturally, there's going to be always variable. There's always outliers, right? That's what the disease is, right? So I think one has to kind of look into that. And I always think that when you look at a thyroid FNA, which is a test, there is a diagnostic portion of it, and there's a screening portion of it. Diagnosing malignancy, a good number of benign nodules, is a diagnostic test. But when you're dealing with these middle group, FNA is a screening test because when you look at cytology, you say, yes, it's a lesion, it's a neoplasm. But if you do not see the nuclear features of papillary cancer and the radiology looks very benign, I think the clinician then have to decide what else to do, or you can always because these tumors grow very slowly. Majority of them are going to be benign, or even those indeterminate lesions on searchback, where we kind of fight with each other saying, it invades, no, it does not invade. It's not an angioinvasive carcinoma, so you're dealing with a low-risk lesion. So I think one has to come from that thought process to really look at these and realize, example, 1.7 centimeter nodule on radiology looks very benign, no suspicious family history. You just have few microfollicles or small follicles that's supposed to be triggered. You have to think twice before you call it atypical or neoplasm. So I think it's a more of a cumulative kind of approach to this, more like a wholesome approach, kind of the bird's eye view, bring in everything to make sure to. So one of my mentors always told me that when you look at a slide and you come from an atypical or suspicious thought, it's very hard for you to go down to benign. You're going to stay in that middle. But if you keep on asking your question that why it's not benign, and you go through that checklist, it's easier to stay in a lower grade of diagnosis than to jump to atypical or neoplasm. So that's my approach to these lesions.
So that you look at the ultrasound, you kind of take that into account, or at least it's a great message, I think, for us, all of us, when we're making those clinical decisions and, shared decision making with the patient, but also, all of that, those factors coming in for an individualized decision as well. That's a terrific point that we kind of sometimes forget. We want to use cytology like a recipe and say, oh, it's this, so we have to do that. But yeah.
I mean, I think that the early parts of the FNA was very, we always kind of practice on a defensive side. We always said, what if I miss a cancer? And there's always somebody who's going to tell you, oh, I've seen that before and turned out to be horrible cancer. But those are anecdotal, rare cases. So you kind of have to approach from a point of view what you're going to see and what you have on the slide and what every other thing that matters.
So how we have the molecular testing, at least in some countries, in some places, that can rule in or rule out cancer in a thyroid sample. How do you use these? Are they as reliable? And what do you suggest? Are they again like a recipe or as an adjunct? How do you look at these molecular tests?
So I think the first thing about the molecular test, when you look at a test, you have a sensitivity, a specificity of the test. But I think one also has to realize the predictive value of the test. So when you're choosing a molecular test, if 95% of the lesions that you see in the thyroid are benign, naturally you want to choose a test. Even if you're looking for thyroid cancer, you want to look for a test which has the highest negative predictive value, which is very important. Now, also one has to be realized that the molecular test, even though they have great sensitivity, good to excellent specificity, and whatever is available commercially is very good, you also have to realize that the cytology bench is the reflex for the molecular test. The things that you call Bethesda 3s or Bethesda 4, atypical or neoplasm, are the ones that are going to go for the molecular test. So I think for me, you kind of have to be judicious, not all, because I think sometimes I feel even I get pressure. When you have this test available, you have to realize, so why should I be calling lot of things benign? Why cannot I just send them for molecular tests because that's the answer? I think molecular tests are excellent, but they are not 100%. We know that what is submitted for molecular test, also depending upon the sample, how the sample was taken, was it an adequate test? Molecular tests are not going to tell you whether the cells that you submitted for molecular analysis are coming from the normal thyroid tissue or coming from the nodule itself. Also, you have to understand the molecular test is adequately looking at the follicular cell component or the cell component. So those things do matter. I think, yes, when you look at the atypical category, the benign call rate of a molecular test is almost 80+%. That will classify it. But my thing is, if you have, let's say you have a 4.5 centimeter TIRO 5 nodule that you biopsied, cytology called follicular neoplasm, and the molecular test comes back negative versus a 1.2 centimeter or 1.7 centimeter, 2 centimeter nodule that the radiology is either TIRO 3 or 2, and the cytology is atypical, molecular test comes back negative. In those two scenarios, one has to exercise caution, right? They have to say, well, this 4.5 centimeter nodule that is slowly growing, even though the molecular test is negative, cytology is follicular neoplasm, you have to kind of decide how you're going to manage that nodule versus the nodule that was very low on the risk stratification for radiology, biclinical, and cytology is called atypical because of few cells. So the bottom line is everything matters. It does fit in the puzzle as an adjunct test to further manage those nodules. But I just think one cannot say the molecular test is the answer for everything. So I think that's where, again, a wholesome approach, everything matters, to bring in to really manage these patients.
That already sounds like a word of wisdom for me. Yes, to take the in context. We don't want to take those out of context. Thank you for tuning into this engaging conversation with Dr. Zubair Baloch. Due to the depth and importance of our conversation today, we've decided to extend our chat into a second part to ensure that we've covered everything thoroughly. So stay with us for more. If you have any questions or suggestions for future podcasts, please email us at voicesofwisdompodcast@gmail.com. We have an exciting season ahead of us, so please stay tuned for future episodes. And if you liked our podcast, Please subscribe to our webinars that air live every Friday morning at 8 a.m. Eastern Time, USA. TIRO Multidisciplinary Seminars is a series for thyroid clinicians and researchers that covers breakthroughs in thyroid cancer research and treatment in the form of topical journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and lively panel discussions. Just visit tyro.expert/subscribe or click in the link in the description. Thanks for tuning into this episode of TIRO's Voices of Wisdom podcast. We'll see you next time. Until then, take care and keep making a difference.